Okay, good evening, everybody. I hope you can all clearly hear me. As introduced by Dr. Brittany, my name is Dr. Humphrey Godwin Medarakini. I am an emergency physician, but as well a lecturer in the Department of Emergency Medicine at Muhimbili University of Health and Allied Science. And I would like to welcome you all to our first MUHAS Emory joint presentation that's going to be specifically based on pediatric emergency medicine. And I'm glad that we're starting a new year with this pediatric emergency medicine series that is going to be every monthly. So for all those that have joined in already and those that I know will be joining in, just always keep posted that this series is going to be happening every month. And we'll keep you updated and keep you posted whenever we have all the meetings so that we can all catch up with the series and we cannot miss anything as we try to advance pediatric emergency medicine in Tanzania. So today we'll have our first topic, that is the general emergency medicine approach to pediatric patients, that is going to be presented by first Dr. Juma Mbugi, who is a pediatrician at Muhimbili National Hospital, but also he's the head of pediatric emergency medicine unit at Muhimbili National Hospital. And the next presenter is going to be Dr. Rees, who is an associate professor of pediatric and emergency medicine. These are going to be our presenters for today. And if you have any question, if you want to ask any clarification, you can just put it on the chat. And Dr. Brittany should be moderating all the questions and every question will be answered appropriately. This meeting will be recorded so that if you want the recordings and try to see the knowledge later, it's going to be easy for you. But before we kick off the presentation, I would like to welcome the head of department, Dr. Said Kilindimo, who is the head of department, emergency medicine, MUHAS, so as just to give an introduction before we begin the presentations. Dr. Said, you're welcome.
Yeah, good afternoon, everyone in Tanzania. Good morning to colleague in Emory. Welcome and Happy New Year to everyone. We're excited to welcome you in this pediatric emergency medicine series, which we're going to having the session as what moderator said, that will be on every year. Not much to say than to thank you, the audience, for your time and dedication to want to join us. And actually, we're trying to make this for us, for Tanzania, and seeing how we can improve pediatric care in our setup. So this will be like guided or targeted to a practitioner and emergency medicine practice in Tanzania. It is for us. So the decision you made to join this session, I think it's wonderful and it's important decision. And from today, in a monthly basis, encourage even our colleagues to join us on this session every month so as we could all work together to improve our emergency medicine practice in the country. Let me take also this opportunity to thank the presenters for their time to prepare this talk, but more important, Emory University to agree to join with us in this session of pediatric emergency medicine. What we do is just like an introductory to a bigger important occasions which our department is trying to do through the university. As well we know, we are in the process of hosting pediatric emergency medicine as super specialization in the training at Muhimbili University. So this session will be like an introduction for those who want or to create awareness, but more important for us to learn how to work together in emergency medicine. Let me promise you, this series of pediatric emergency medicine is medical council accredited course or series of lectures. It has a CPD points, so please give us your MCT number to the text while we continue the presentations. Your full name, your institution you work, and your medical council registration numbers, so as we could process your CPD points at the end of the sessions. Otherwise, let me take this opportunity to thank you again, Dr. Britt has been heading to us a discussion on this modulation for this program, which is we think is going to kick off today, and all of this going ahead. Having said this, let me say this pediatric emergency medicine series has been opened and welcome for the coming sessions. Thank you.
Thank you, Dr. Said, for the remark. So without now wasting time, I would like to welcome the presenters to begin presenting. You are all welcome.
Thank you, Dr. Humphrey.
Go right ahead, Dr. Juma. And just for those in the audience, we can all see when you're writing on the screen. It might be a little distracting, so let me try to unshare and share again. Hopefully that will erase those marks, and we can get started. There we go. All right, over to you, Dr. Juma.
All right, thank you, Dr. Chris. My name is Juma Mbugi. As Dr. Humphrey introduced me before, I'm working at the emergency department here at Muhimbili National Hospital. So our topic today will be the pediatric assessment triangle. The main topic is the general approach to pediatric patients at the ED. And our outline is pediatric assessment triangle, primal survey, and sample history in children. So the pediatric assessment triangle objectives to distinguish the three components of the PAT. The PAT has 3 arms, so we'll see what are those arms, and assess pediatric specific features of initial assessment, and also to integrate findings to form a general impression. So pediatric assessment triangle, abbreviated as PAT, this is a rapid assessment that quickly and efficiently assesses an unwell child to determine if immediate intervention is required. So it's usually undertaken in less than a minute. It acts as a visual triage, but takes less than a minute to complete it. And PAT assists in identifying red flags, and it uses familiar language of communication of patient status between clinicians. So as you can see, the triangle, it has 3 arms: appearance arm, the work of breathing arm, and the saturation to skin arm. The appearance arm, this acts as it reflects the age of the child and stage of development, and also the interactability to the environment. So the appearance arm look for tone, interactiveness, consolability, the look or gaze, and speech, cry. This is the strength of the cry of the child. And then there is a work of breathing, of which you look for abnormal airway sounds, abnormal positioning, retractions, and nasal flaring. And circulation to skin, you look for pallor, mottling, and cyanosis. So in this triangle, whenever you find any abnormality in any of the 3 arms, that means that child is unstable. So after that, you have to form a general impression, like a child is stable. You can say a child is stable, a child has respiratory distress, respiratory failure, shock, CNS dysfunction, or you can have an impression of cardiopulmonary failure or arrest. So we have, the impression can be tabulated in the following manner. This is just an example. For instance, a stable child has normal appearance, has normal work of breathing, and has also normal circulation to skin. For instance, again, respiratory distress child, appearance can become normal, but the work of breathing is abnormal, and the circulation to skin can be normal. For instance, in the cardiopulmonary failure, appearance can be abnormal, and work of breathing will also be abnormal, and circulation to skin will be abnormal. We can see in the following cases. So we have how to apply the PAT. We have 3 cases that we can see how to apply the PAT, the pediatric assessment triangle. So case 1, 1-year-old boy presents with cough and difficulty in breathing. So the boy has a past history, which is unremarkable. He has had nasal congestion and low-grade fevers for 2 days. So how can we formulate a PAT here in this case? So appearance, work of breathing, and circulation. So appearance, the child is alert, smiling, and non-toxic. And the work of breathing, the child has audible inspiratory stridor at rest. And the circulation, the child is pink. So what information does the PAT tell you about this patient? So if we remember, we have to make a general impression and come up with, we have to make a general assessment and come up with a general impression. So what the information does the PAT tell you about this patient, and what's your general impression? Let's see. So the assessment here, the PAT of respiratory distress here, appearance becomes normal because the child doesn't have any abnormality in appearance. And the work of breathing is abnormal because the child is having inspiratory stridor, and the saturation also is normal. So we have normal appearance, abnormal work of breathing, and normal saturation. And the general impression here is respiratory distress. So the case progression, so initial assessment, you can say the child is having the respiratory distress with the most likely upper airway obstruction because of the inspiratory stridor. And why do we do PAT? We do PAT because it guides us to make priorities, treatment priorities. So having known that this child is having respiratory distress with upper airway obstruction, and then our initial priorities in terms of intervention will be leave a child in a position of comfort, obtain oxygen saturation if needed, and provide oxygen as needed, and begin specific therapy of the upper airway management. So case 2 again, let's see how we can apply PAT in this case of 3-month-old boy that presents with severe difficulty in breathing and seen in ED 2 days area, sent home with a diagnosis of bronchiolitis. And her difficulty in breathing has increased with time. So the pediatric assessment triangle here will be appearance. The child is appearing lethargic with poor muscle tone and a glassy stare. Glassy stare means the child is kind of having fixed gaze or uncomprehended. And work of breathing, the child is having marked sternal and intercostal retractions, rapid and shallow respirations. And circulation, the child is pale with Sakamoto cyanosis. So general impression, and how does this impression guide you in the management? So general impression here, this child is probably having respiratory failure, or you can say cardiopulmonary failure, because everything is abnormal in the 3 arms of PAT. And the management priorities will be support oxygenation and ventilation with a bag mask, and probably prepare this child for endotracheal intubation. And as again, you have to do the assess the cardiac function and have an IV or IO access. Continually reassess this child after every intervention provided. And the case 3 is a 15-month-old boy with a 24-hour history of vomiting and diarrhea. Diarrhea is watery with blood. Oral rehydration by his mom was unsuccessful at home. So child became listless and refused feedings. Let's see the PHE. So his PHE will be, the appearance is listless. Listless means drowsy, or you can say lethargic. So the child appears listless and responds poorly to environment. And the work of breathing, the baby has effortless tachypnea with no retractions. And circulation, the child is has a pelvis and trunk plus motor extremities. So what's the general impression? Initial impression here is shock. And the shock could be caused by excessive vomiting and diarrhea with hypovolemia. Management priorities. So the PHE, as I said before, it guides us to have management priorities, which child to run into first and which intervention should be done first. So management priorities here are provide oxygen by mask, obtain quick vascular access, preferably by IO if IV will take time, administer volume expanding crystalloids available. We normally use normal saline or Ringer's lactate at that 20 mils per kg, and continuously reassess the patient and complete the general examination. So pediatric assessment triangle, it gives you the first impression, and actually it guides you the immediate intervention to be done, the treatment priorities of that particular patient. So generally begin with when you receive a kid at your place, say at emergency department, you begin with pediatric assessment triangle. This is a quick visual triage. It takes less than a minute. And then you follow by doing ABCDE assessments. So PAT, you form a general impression that will always guide you in management priorities.
Thank you very much, Dr. Juma. It's really a joy for me to be here, so thank you for the invitation, and it's nice to see many familiar names in the Zoom. As was mentioned, my name is Rees. I'm a pediatric emergency medicine physician at Emory University. I've long been collaborating with individuals at Mbugi primarily in the Department of Pediatrics and more recently in the Emergency Medicine Department, and lived in Malawi for a time and have done a bunch of consulting for the WHO related to child health. So I'm very happy to share some of the sort of high-level things that we would hope you'd think about when doing the primary survey in children, because as I'm sure you've heard before, clinically, children really are not little adults, and there are specific nuanced differences that we need to be aware of and take into account as we provide clinical care to children in contrast to adults. And I would venture to guess that many people on the call are very familiar with this concept of the primary survey, the very simple ABCDE. We're emergency medicine people. We like to keep things simple, especially when we're in an environment when there's tremendous distractions. So keeping kind of a generalized and reliable approach is very, very important and can often help you in those moments when you're feeling a little bit nervous about what's going on with the child because you can't quite figure it out. I think many of us who practice clinically like to figure out what the problem is and then try to fix the problem. But sometimes children come in entirely undifferentiated and we don't know what's going on. And so it's nice to have this sort of systematic approach to addressing the most critically important issues first. And then kind of moving forward. And again, there are these unique considerations in children that we thought it would be worth highlighting, and that's what I'll do in the next few moments here. A couple of things with the primary survey that we thought would be very important to impart on you is number one, if there's a problem with one of these, stop and address that problem before moving on. In other words, if that child's airway is unstable, don't start listening to their lungs and assessing their breathing and circulation disability and exposure. Fix the airway problem. I think people often think, okay, I need to go through this checklist and come up with all of the things that I need to address and then go back and address them. That's really not the design of the primary survey. The primary survey is meant to be start with this problem, address that problem. Once that problem's addressed for the airway, if it were, move forward. If the problem's with breathing, you stop at breathing. You address the breathing problem before you move on. So that's a very important piece that I think will also help with that kind of anxiety that often pops up while taking care of children, especially when they're critically ill and especially when there's some indifferentiation in terms of what's going on with them. The second sort of general principle that you may have heard before, it's not necessarily unique to pediatrics, but if you're going through your primary survey or even at your secondary survey, if the patient decompensates at any time, go back to your ABCDEs. Chances are the problem can be fixed by going back to the basics and again, going through that systematic approach and addressing things as they arise. So what I'm going to do is go through each of the A, B, C, D, E, and kind of point out some of these unique considerations in children. Because again, they're not little adults, and we need to be thoughtful about all of these different things. So in terms of airway, unique considerations, children in comparison to adults have a higher minute ventilation. So we'll show you some normal vital signs for children in just a moment. And their respiratory rates are much higher. Their minute ventilation is much higher. They also have higher metabolism than adults. They're burning through calories more rapidly. They're requiring oxygen at a different sort of pace, simply because of this increased metabolic demand in comparison to adults. They also have a smaller functional residual capacity, so there's less air that can be retained in the lungs at any given time. A lot of that is just anatomy, but also physiology plays into that as well. They're just smaller individuals. So what does all of this lead to? Well, importantly, children in comparison to adults can desaturate much, much faster because they have this higher minute ventilation, higher metabolic demands, and a smaller functional residual capacity. Moreover, that means that they can tolerate apnea for much less time. And so it's really, really important that we be thoughtful about this. But especially if you're going through your primary survey and you find that a child needs to be intubated, that's always the big one, right? When we talk about the airway, if you need to intubate them or if you need to, do a cricothyrotomy or a tracheostomy or whatever the case may be, there's going to be some things that go through your head. And one of the things that we should be thoughtful about is given their increased risk of desaturating more rapidly, their ability to tolerate apnea for less time than adults, we need to pre-oxygenate, meaning put on supplemental oxygen in some format while you're drawing up your sedation medications, getting your drips ready for after sedation and so on, or for after intubation and so on and so forth. You're getting your materials. All of those things, just simply put oxygen on the child, let them kind of fill up the lungs as much as they can with some good supplemental oxygen, because that's going to help buy you a little bit of time when you start to take a look and you're trying to intubate. And if, there's some unique considerations that I'll point out as well with the anatomy and physiology in just a moment here. But pre-oxygenating is really, really important. And I'm not going to show the primary data, but it's been shown to actually increase odds of success with first-time intubation pass and everything else. So very, very important that we keep that in mind. This table goes through a few of the important anatomic differences that we wanted to point out. First is, I'm sure you've appreciated, children just have larger heads. in comparison to adults, right? Bodies don't grow, body parts don't grow at the same rate. If they did, we'd look rather funny as adults. We'd have very long arms and very long legs and so on and so forth. And our heads would be enormous. But at any rate, it's important to keep in mind that children relatively have a larger occiput or a larger head in comparison to adults. And so what does that do? That leads to this challenge that we have where we need to line up these three axes, the oral axis, the pharyngeal axis, and the tracheal axis. If you see in this figure here, the oral axis, really, and if a child's resting comfortably, given the size of their head, you can see that that's kind of a straight line back. But what you're trying to do is put a tube that goes this way. So how in the world do you do that? Well, you're trying to line up these axes, and that can be done in several different ways. One of them is by simply putting a blanket or something underneath their head, which, as you can see, starts to align this a little bit more. But even better is putting a blanket under the head or a shoulder roll and doing a little bit of jaw thrust. You can see that now these lines almost kind of line up in a straight line. So when you're going in with your blade and your endotracheal tube, you actually have sort of a straight shot as opposed to trying to go around this corner, which is a much more challenging way to try to intubate a child. So it's a very important thing to kind of keep in mind. And a couple of other things with that. It's important that in infants, oftentimes a shoulder roll can help align the airway a little bit better. Older children and adolescents frequently benefit from elevation of the head, similar to what you see in adults. So that's why this image with a larger child or an adolescent, I don't know their age here, but you can see that there's more alignment as simply with that blanket underneath their head. So important to keep that in mind. They also have a relatively superior airway, and I'll show you an image of this in just a moment, and we'll also look at a video here in just a minute that I think will kind of illustrate this a little bit better. So in contrast to adults, oftentimes when you intubate a child, what you're going to see is this. So you can see your arytenoids, you can see your epiglottis here, but you can't see where the tube needs to go. So that's what I'm trying to say to you is two things. One, be aware that that's an issue, but then two, this is a good opportunity to have somebody put some cricoid pressure on that child's neck. So if you get in and you're looking and you see something like this, it'd be a great opportunity to have somebody kind of put some pressure on the neck, and that can kind of bring those arytenoids down, and you might be able to then visualize the vocal folds and subsequently intubate the child. So very important to keep in mind here. Their epiglottis is also much larger. If you're intubating, a neonate or a young infant, you may think about using a straight blade, like a Miller blade, as opposed to a Mac blade that's curved. The reason for that is you may want to just get right underneath the epiglottis to get a good look at the vocal folds while you're intubating. A second opportunity there is that you can engage what's called here it says the hypoepiglottic ligament, or the hyoepiglottic ligament is the other name. This is a ligament that goes from the hyoid bone to the epiglottis, as the name sort of implies. And what it does, I'll show you in just a moment, but once you engage it, it makes that epiglottis flip right up so you can get a good look at the airway that you're trying to get to. So that's what this is here. This is that hyoepiglottic ligament. You can see here, their blade is not anywhere near that. So that big epiglottis is right down in front. Here, they're beginning to engage that. They've kind of advanced the blade. I'll show you a video in just a second. That will make this more clear. But then once you've engaged that ligament, you can see, there we go. That's exactly what we're looking for. That's the view that we want to be able to pass our endotracheal tube. So let's look at a video, and I hope this works. Looks like it's working. So here, we are passing our blade. You can see we're in the oropharynx. Oh, there we can see our epiglottis. Oh, we can see our folds, but it's not a great view. So they back up a little bit, and they go back, and this time they're going to try to engage that hyoepiglottic ligament, and look at that. Beautiful, beautiful view, and you can pass your tube just like that. I'll take a moment and just mention that as well. In contrast to adults, children have a shorter airway. So when you're actually passing your tube through your vocal folds, you don't want to go very far. You really want to go just kind of past where that cuff is if it's a cuff tube. If it's an uncuffed tube, you just want to advance just slightly beyond those vocal folds. because you don't want to put that endotracheal tube in the right main stem, because that's going to lead to suboptimal oxygenation and ventilation, of course. So remember, anterior airways, engage your hyoepiglottic ligament. That is your friend. So breathing, there are certain differences as well that we should be aware of. We've kind of talked about our A's. Now we'll talk about our B's here. First and foremost is that the rate differs. If you were to see an adult who's got a respiratory rate of 40, you're nervous. You're nervous that they're in respiratory distress or respiratory failure. If you see an infant whose respiratory rate is 40, 50, even 60, you may not worry quite as much. And that's a very important concept to keep in mind. The intent of putting this up, this is from the Pediatric Advanced Life Support, which is sort of an accrediting body that helps with some of these that helps with acute management and acute approach to children who have respiratory distress, cardiovascular distress, so on and so forth. The intent here is not for you to memorize these numbers. This is something that is helpful to have in your brain, so that you don't have these moments of panic when indeed you don't need to panic. But just know, infants breathe a lot faster than toddlers. Toddlers breathe a lot faster than preschoolers. School-age children breathe faster than adolescents. And once an individual is an adolescent, then they're kind of in that area, in that range where you may be more comfortable sort of managing or knowing what the respiratory rate is, because it's more familiar and more similar to what we see in adults. Another thing that may be different in children that I thought was worth mentioning is that the signs of respiratory distress in children are different. Sometimes they'll come in if the child's got epiglottitis or tracheitis or whatever, and they may be extending their neck or even tripoding, which means kind of bending forward and using their hands to kind of keep themselves upright. That's like a position of comfort, which helps them open the airway. Not really something we see with adults, and it simply has to do with anatomical differences. Again, children have much less real estate, much less space. So when things get inflamed and swollen, it becomes a problem much faster. Another thing that we see in children is nasal flaring. Their nostrils will flare, and that if you see that, that tells you, oh, they're using extra muscles just to simply ventilate and oxygenate. You'll also see tracheal tugging, or recessions was the word that we used when I lived and practiced in Malawi. You'll see head bobbing, so the head will actually be going up and down. It's kind of a late sign of respiratory distress. Retractions, or chest indrawing, as the WHO calls it, abdominal breathing. That's also a form of indrawing. And then stridor and grunting. These are all signs of respiratory distress that you may not necessarily see in an adult, which I thought was worth mentioning as we talk about differences between adults and children related to respiratory distress and breathing aspects. Another thing, this is more specific to trauma, but again, since this is an emergency medicine series, I thought it was worth mentioning, is that pulmonary contusions are more common when there's trauma on the thoracic wall in children. The reason for that, as you can see in this diagram, is that children's ribs are much more compliant in comparison to adults. So oftentimes they'll be struck with an object. Here you can see a motor vehicle, which, as we all know, is a very common scenario, unfortunately. Struck with this object, there's that increased compliance on the ribs. Instead of those ribs breaking, there will be no rib fracture, but rather a massive pulmonary contusion. And that simply has to do with the fact that, again, they have more compliant ribs in comparison to adults. So again, just a few kind of high-level things that are different about children in comparison to adults as it relates to breathing. So we've done our airway, we've done our breathing. Now let's talk about circulation and some differences that are worth knowing about children. First, just like the respiratory rate, heart rate varies by age in children. This really has to do with stroke volume, right? If you remember, cardiac output equals heart rate times stroke volume. Blood. And so in order for the demands of all the tissues in the body, a smaller heart needs to beat faster. So that's why you see in a neonate, you'll see a heart rate as high as 100 to 200, and that's considered normal. And that just seems crazy if you think about an adult with a heart rate of 200 and thinking about it as being normal. An infant as well can have a heart rate as high as 180, and you're still not rushing to grab the pads and EKG and all those things. Toddlers as high as 140, preschoolers 120, school-age children 118. You can see these are sort of rough numbers, but they're all based on sort of nomograms of children and normal heart rates, as it were. So keep in mind, heart rate varies by age. And again, the concept is the younger the child, the higher the heart rate that's normal. And as they get into that adolescent age, that's kind of more, you may be more comfortable with that heart rate if you are primarily an adult practitioner. Another thing to be aware of is that there are differences in terms of access, right? And I'm talking about central access here. Peripheral IVs can also be more challenging in children, and you can also often think about, scalp lines and things along those lines. But central access, if you need to put in a central line for some reason, oftentimes we'll think about putting in like an internal jugular, an external jugular line of some sort. But that's not going to work in an infant who's got a neck that looks like that with so much adipose tissue. So instead of thinking about the neck as a site for central access, primarily in children, think about the femoral lines. They're a great opportunity. They're a great location to put in a central line if you get to that point with a child who's got, as Dr. Juma was pointing out, cardiovascular collapse, or they're in septic shock, or whatever the case may be, where you need that central access. Just be aware that if you have this capacity to put in a central line, don't go looking for those vessels in the neck, because it's going to be hard just from a real estate perspective as well. So disability. So now we're on our Ds here. And I'll make sure that I leave some some time for Dr. Juma. So don't worry here, Dr. Juma. So disability. I'm sure many of you are familiar with the Glasgow Coma Scale score. There's also the Blantyre Coma Scale. I'm not going to go through the specifics here, but if you think about some of these components and you think about what children of varying ages are able to do, if you look at motor response, obeys commands for movements. If you've got a 6-month-old child, they're not going to obey commands for movement, even if they're 100% fine. So there are some subtle differences in the pediatric Glasgow Coma Scale score that you should be aware of. Eye opening is largely the same. Verbal responses, that's where it really starts to vary. And you can see in this table, it's sort of stratified by different age groups, because again, developmentally, they may not be able to do what you're asking them to do, just to assess their mental status. Another thing that's important here is you may need the parents around in order to assess the pediatric Glasgow Coma Scale score. This is important because you may have no idea if that 12-month-old is saying one word or if they're saying 20 words. So you don't know if it's abnormal that they're just saying dada when, that could be a very developmentally advanced child who's able to say a lot more than just one word. Another thing to be aware of as it relates to disability is that head injuries are a very, very common cause of injury-related death, and in fact, one of the most common injury-related reasons for emergency department visits. So I'm not going to spend a ton of time on this. It's one of my favorite things to talk about, but there is what's called the PECARN Pediatric Head CT Rule. PECARN stands for the Pediatric Emergency Care Applied Research Network. It's a very large research network in the United States and is coupled with other research networks throughout the world in the Pediatric Emergency Research Network, or PERN. But the upshot of this is that there is this tool that you can use to help make the decision as to whether or not you need to do a CT scan for a child. I thought that this was important to point out because I recognize that many of you practice in settings where you may not have access to a CT scan. And so you might think about pulling this up. If you've got a child who's got a head injury of some sort, you can pull this up, go through this, and that might help you in the decision as to whether or not you need to transfer that child somewhere where they need to get a CT scan. And of course, if you are somewhere where you have access to CT, this can help you sort of risk stratify and make that decision as to whether or not you need to pursue the CT scan or not. Lastly, as it relates to the ABCDEs and exposure, there are certain unique considerations that, again, we should be thoughtful about. And it really just comes down to their higher surface area to body mass ratio. This is something you may have heard through your studies at some point. They have more skin surface relative to their weight. This is because children have a larger head, as we've already talked about, and their limbs are larger relative to their overall body size. This makes them more susceptible to heat loss because they have this greater surface area through which heat can escape. This is why more children are vulnerable to hypothermia, which I realize in Tanzania may not be as big of an issue, but just know that children do lose heat more than adults. They also lose fluid more rapidly than adults. Again, it has to do with that higher surface area to body mass ratio. This makes them more prone to dehydration, especially in hot weather. So this is something to definitely be aware of. And then the last thing is, because of this difference in their surface area to body mass ratio, they absorb substances more often. So if they're around, who knows what, some spill that occurred or whatever, and you see a massive amount of people who are flooding your emergency department with exposures, as you're decontaminating everybody, be extra thoughtful about those children because they're going to be the ones who absorb a little bit more than adults with whatever it may be. So just a few sort of take-home points here as it relates to the primary survey before I pass it over to my friend and colleague, Dr. Juma. Again, there's certain differences and certain implications in children in comparison to adults as it relates to the primary survey. You know, Dr. Juma and I were talking about bringing in the secondary survey to this lecture, and as you can see, we've only got 11 minutes left. The secondary survey has so many different nuanced differences in children in comparison to adults. So we thought for this lecture, we'd really just focus on the primary survey differences. So here's just sort of a summary. I'm not going to go through these again because we kind of talked about all of them. I guess I didn't mention this. This dropped out as we were swapping slides and so on and so forth. But remember, in children, you don't see hypotension until as a late finding. So we often think about shock as being, inability to fully deliver oxygen to tissues and so on and so forth. And we can often measure that clinically with hypotension. Children don't really do that until it's really, really late in the course of a septic shock, for instance. And that has to do simply with the fact that their blood vessels aren't filled up with all this cholesterol and calcification and everything else, and their hearts are actually quite strong and function for the most part, as long as they don't have a congenital heart disease. So I leave you with that section, and I will pass it back over to my pal, Dr. Juma, to round us out with the sample history. Dr. Juma?
Yes. Here. Thank you, Dr. Chris, for the nice presentation. As we said, we talked about area that in the assessment of the child at ED, we start with PAT, the pediatric assessment triangle, and then the ABCDE and sample history, followed by secondary assessment. So now for today, we will end up with the sample history, and secondary assessment, I think our moderators will arrange for some other time. So the sample history, the objectives here is to list the elements of the sample history and perform a relevant sample history. So what are the elements of sample history? So sample is a mnemonic for the signs and symptoms. S stands for signs and symptoms, allergies, A, and M for medications, and P stands for past medical history. L stands for last oral intake, and E, events surrounding the injuries or the illness that the child presents with. Next slide, please. Thank you. So of both adults and children, but today we're going to look at in children. And if a patient has airway, breathing, or circulatory life threats, so gathering a patient history is secondary to treating those time-sensitive of an allergen or exposure to an allergen.
Dr. Juma, I think you might be having network issues. It's very hard to hear you. I'm not sure if it's my side or if others are struggling as well.
Yes, it is difficult to hear.
Thanks, Brittany. Dr. Juma, do you have a...
Signs and symptoms. So it depends. There is no formula present with different presentation. Do you hear me now?
We do in this moment. Yeah, please go ahead.
Okay, thank you. Can I go back one slide maybe?
Sure.
Here, thank you. So sample questions are asked of any patient, both adults and children. And if a patient has airway or breathing circulatory life threats, gathering a patient history is secondary to treating those time-sensitive and life-threatening conditions, like removing an upper airway obstruction, or let's say performing chest compressions. So sample can help identify the cause of medical condition, like anaphylaxis, secondary to ingestion or exposure of an allergen. And the signs and symptoms, these are you ask questions that are focused based on the presenting complaints, because children will present with different presentations. And there is no formula of which questions are going to be asked here. You will ask questions based on the complaints. And for instance, you will ask about the vomiting, and is there any vomiting or diarrhea, and for how long? So you want to quantify the vomiting and diarrhea, for how long. This is a quantification. So why do you quantify? Because you want to know how will this lead to probably shock. And is there any confusion or unusual sleepiness? In the setting of trauma, this question is crucial because you want to see if there is any sign of head injury. Fever, so fever, think about infection. Allergies, why do we ask about allergies? So ask about, are there any allergies to medications? Severe allergic reactions can lead to shock. We all understand allergic reactions. If it's severe, it can lead to shock due to increased permeability and the vasodilatation. So ask questions about allergies to medications or to other allergens like nuts, things like that. And medications, so you ask questions, is the child taking medications currently? Or is there any introduction of new medications or recent dose changes? Why do we ask those questions? Because the overdose of some medications can cause shock. Examples, there are some anticonvulsants and antihypertensives that if you overdose them, they can lead to hypotension or probably shock. Is the patient, let's say, using blood thinners? So why blood thinners? So ask about blood thinners because they can worsen the bleeding if the patient is having any risk of bleeding. And new medications or changes to medications can also cause allergic reaction or unexpected side effects related to the presenting complaints. So it's good to ask about the current medication or new introduction of medication or recent dose changes. So in children, we usually think about, the accidental ingestion of medications. So always do not just ask medications that the child is using, but also ask about the possible medications that the caretaker or the parent, the guardian is using as well, because the child might have a possible accidental ingestion of medications. And this should always be on our minds, that the possibility of an accidental ingestion of medications is high in children. So remember to keep out of reach of children or for medications. Past medical history, ask the past diagnosis like asthma, diabetes mellitus, infections like HIV, accidents or injuries, including injections, and maybe congenital heart diseases. Ask about past hospitalizations, like including operations and duration of hospitalization, sometimes place of hospitalization, and vaccination status, example, the tetanus toxoid vaccine in the setting of skin penetrating injuries. And L stands for last oral intake. Ask when did the child last eat or drink. So this is important because a child who is not eating or drinking well can develop severe dehydration or hypoglycemia, leading to altered mental status or shock. And sometimes the importance of asking the last oral intake is the full stomach puts the patient at risk of vomiting and aspiration. And E stands for events that's surrounding the illness. So ask, what was the child doing when the symptoms or signs started? Was there any recent trauma? So why do we ask about these questions? So think about if the trauma is the cause. So think about hidden internal bleeding, especially if the patient is, the child is presenting with signs of shock. So think about internal bleeding, concealed bleeding. Think about tension pneumothorax. Think about pericardial effusion, tamponade. So if the difficulty in breathing after eating, if the child presents with difficulty in breathing right after eating, think about choking or aspiration. So an accidental ingestion of foreign body is common at ED. So you should always ask about what was the child doing before the presenting symptoms, especially if the child is presenting with difficulty in breathing. So again, if difficulty in breathing with exercise or breastfeeding, this may suggest heart diseases. And any child presenting with trauma, especially if there are multiple injuries or mixed injuries, new and old scars. So always keep in your mind to think about non-accidental injuries. And, you know, for non-accidental injuries, you need to have a high suspicion of the type of injuries that the child is presenting with. And there are to follow procedures for reporting the non-accidental injuries. Again, ask for recent travel, recent exposures, like exposure to sick person, recent bites, pesticides, or inhaled chemicals. Why? Because, for instance, the child had visited the malaria endemic areas. So think about malaria as the cause of the presenting illness. If the child visited in an area with maybe an epidemic of hemorrhagic viral illnesses, so think about EVD, think about chikungunya, things like that. And the pesticides, we understand the pesticides used in farming can be absorbed through the skin and cause fluid in the airways and lungs. We all understand are familiar with organophosphate poisoning. So always think about what was the event that led to the illness. So in summary, in our presentation, we said when a child comes to ED, so first pediatric assessment triangle that takes less than a minute, and this guides you to prioritize your intervention. So the PAT, the pediatric assessment triangle will guide you to which patient to run into first and which intervention to be given first. And then comes the primary assessment of the child. This is A, B, C, D, E. Dr. Chris has already talked about it in details. And then the sample history. This is a short history done at ED, not as a proper pediatric history that we take out outside the ED. And then the secondary assessment that is not going to be talked about today until next time when the moderators arrange that. So that's it for today. Thank you so much. Asante sana, merci, sheshe, gracias.
Thank you very much, all the presenters. Thank you, Dr. Juma Mbugi. Thank you, Dr. Chris, and Dr. Brittany on the background, where she has been looking on the charts. I know looking on our time, it's 2 minutes past the agreed time, but we'll just allow 3 minutes. If there'll be any questions in the chats, one can just write a question so that we can quickly answer the questions. Because it's going to be, it might be difficult all speaking via the Zoom, but if you have a quick question, you can just type it in the chat. But as well, for all that have attended, please remember to write your MCT number, your place of work, and full name so that we can easily follow up when we're trying to look for the CPD points from MCT. But again, I would really like to say thank you to everybody who has joined us. Keep posted. We'll have our next presentation on 12th of February, which is going to be about fluid management in pediatric patients at the emergency department. So just stay alert. We will have the announcements coming in. So make sure that you don't miss out any of this, as it's going to be a progression of this lecture series. So Dr. Britt, you're welcome. If there's any questions that has been said so far.
I don't see any questions at this time, so I think we are good. Thanks everyone for joining. I will keep the chat open for just a few minutes so that everyone can get their MCT numbers, name, and place of work in the chat, and we can work on getting you the CPD points.
Okay, that's great.
So there is one question in the chat, that is how do participants get notification for the next session?
Okay, thank you for the question. So currently what we are doing right now, we have posters that will be circulating using different social medias. The department has a social media. Let me just type it in the chat so that people can join in, so that they can always have an update of the presentations. So we have a Twitter media and as well as a social media that is Instagram, where we'll post these updates and announcements so that people can easily know like when is the next presentation and how to join in. So I'll quickly just write it here. So I've just shared the link whereby you can join in and follow, where we'll keep you updated on the announcements of the next lectures that will be coming. But the next lecture, just to remind, is going to be on February 12th.